All right. So, you know, gait is so important. Locomotion is a more collective term because not everybody walks. But a lot of the times we'll be looking at gait and how do we walk. And adding the assisted device for a patient to walk to enhance their gait is a really, really detailed thing to start thinking about. Just like in week 1, when we looked at all of the details and rolling over in bed, we've got plenty of details with this that we've got to cover as well. So, we want to improve somebody's gait, but we can't just throw a walker at everybody because walkers have advantages and disadvantages. Same thing for canes, same thing for everything else. With gait, the number one thing we have to be concerned with is energy expenditure. Any gait alteration, any gait deviation, and then especially once we start adding devices, it significantly changes the energy expenditure to walk. And you come home, you can come home with me if you want. But if you come to my patients' homes, you'll see the patients who struggle to walk to the bathroom. That distance is a taxing distance. So if we were just to say, looks like you're a little unstable, here's an assisted device, now they might not be able to make it to the bathroom because of the energy expenditure required now. So it's not just a simple throw this at them, although there's plenty of people that do just say, throw this at them. So what other things do you think we have to try to balance when we look at assisted devices and the variety of assisted devices that we have? And balance is probably the number 2 thing, right? So, the energy expenditure, then balance. The balanceability is probably the number 2. Yeah. Any other considerations? Coordination, definitely. I've got plenty of patients that are a fall risk. We add assisted device to try to lower that risk, and they are so uncoordinated with their assisted device that it actually makes them a higher fall risk when they're using a cane or a walker or crutches than without. So definitely. What other considerations? Overall strength. And tell me more about what you think about that.
They have to have the strength and the ability to use the device that
Yeah, so all of these devices require hand use. So we have to have grip strength. We have to have ability to weight bear through our arms, at least to some degree. So yeah, that's a big, big difference. Yeah. Any others? Any other considerations you think? Cognitive, yeah, the cognition is a huge piece of it, and similar to, but not exactly coordination. We have a patient that can be cognitively intact, but has coordination. We could also have a patient who's just cognitively has a lot of trouble learning how to walk with this assisted device. And actually, this happened just yesterday. I had with the patient. She told me about her friend that her husband just got diagnosed with dementia, and I said, "Listen, I don't know anything about the guy other than he was just diagnosed with dementia. Start looking at if he needs a walker or not, because if he needs a walker, we'll just teach it to him now." Rather than in 3 years when he physically needs it, but cognitively he won't be able to understand it. So if we've got a shot at it, we've got a shot right now. I mean, I don't know if we do or not, but that was my piece of advice for them. So yes, cognition is a huge piece that we have to consider. Any others? What is it? What was it? I can't hear you. Oh, endurance. Yeah. Sorry. Yep. Yeah, definitely a piece of it. Yeah, with the energy piece of it. And also some patients, I've got some patients that don't leave the house. So some of those people, I'm not concerned with their endurance. So I mean, all of these things are things to consider. Just like our list of things to consider with exercise, right? We have a huge long list, and some of them are really important. Others are sad. Don't worry about that one. So all of that stuff and even more we'll learn a little bit other things to consider. Another important one is cosmetic. Convincing our patients to use an assistive device. I told you a couple times about my 103-year-old wonderful lady. She didn't want to use a walker going to church because she didn't want to look old. She was 103. Like, okay. So getting our patients to actually comply with the assisted device is really important, and there's a lot of reasons why they wouldn't want to comply with it, including cosmetic appearance. So let's look at a couple other things to look at. We're going to use them for, like we said, balance, impaired strength, maybe coordination, pain, absence of limb, altered stability. The goal is to improve mobility without limiting them. We call it the least restrictive device available. Enhanced body functions. I don't like the way this is worded, assist with fracture healing. We're not really assisting with fracture healing. We're able to ambulate with altered weight bearing status, and not weight bearing through a fractured limb is going to make sure it heals. So it's a funny way to word that. But we want optimal safety, increase in function with the least energy expenditure. So it's that balance. And just like with, I think with the wheelchairs, we saw balance a lot. You know, are we okay with this being a little bit off this section of it because everything else looks okay? Or are we really concerned about that piece? So it's a lot of things we have to cover. You guys all learned gait and kinesiology? Did you guys start covering gait yet? All right, I don't think a lot of the details that you're going to learn in kinesiology that we will need for this, but if I mention something and you don't know what I'm talking about, let me know and I'll stop and I'll have to really think, okay, do you need this for this class, or do we just tell you focus on that? So please interrupt me if you don't. Did you have something, Carlos? No, okay. So just to recap for some of us, again, it's not all that important in this class, but it's things that we should be aware of, and it will pop up on your licensure exam. So we have swing and stance phases of gait. Swing is 40% of the gait cycle. Stance is 60%. We could have single limb support or double limb support phases. Gait speed is really important. We have the gait cycle that are all the different phases and subphases. We have all of that information at the end. So if you wanted to start looking at that, that's important. So here's all of the breakdown of the other phases of the gait right there. So the energy expenditure with gait, we have 6 determinants of gait that affect the center of gravity. The larger the displacement of the center of gravity, the increased energy expenditure. So the transverse pelvis rotation, the pelvic tilt, anterior posterior pelvic tilt, knee flexion during mid stance, foot and ankle motion, knee motion, and lateral pelvic rotation. All of those are the big determinants of energy expenditure with gait. Also, one of the things that we don't focus on right here, but we will start to, is just how much weight is the device that we're adding to them. That is another piece of factor. And how muscles are working and when are important information that you already know. So, but in order to prepare for ambulation devices, I mean, there's so much thinking that gets involved. You know, we haven't really moved with our patient yet in our class. Like, we've done bed mobility, we've done some transfers, but then that's it. Now we're going to be thinking about how do we walk with our patients who have poor walking ability, and that can be really scary. But with good planning, we're going to be able to really execute this in a safe manner where, I mean, we're feeling good, patients are safe. So first up is your chart review. What is their weight bearing status is the number one thing we have to look at when our patients are, when we're going to be ambulating with our patients. That will also, the weight bearing status will also help us determine which assistive device is most appropriate. It will also help us determine which gait pattern that we played with a little bit last week, which selection of gait pattern is going to be real important. So I would say that's the number one thing. Number two, strength, others, pain, cognitive ability. we're going to be looking at our patient to determine their limitations, determining appropriate equipment, gait pattern based on that review. So all of that should be in our head before we even see the patient, just with our chart review. And then we're going to start looking at our patient and set up our actual treatment area. First thing is setting up your treatment area. So making sure that you have a plan. You can't just say, hey, let's get up for a walk. And then you look around and realize, where am I going? What happens if something goes wrong? I can't believe I left that in the way. It is a terrible feeling when your patient is doing worse than you expected and you don't have a plan. That is a recipe for disaster. So clearing the paths, eliminating trip hazard, making sure you have an exit plan. Where are we going to bail when this starts going wrong? And how close is that to where I am right now? So it's way easier to be surprised when our patient's doing so well, then we can come up with the next thing to do, rather than, holy cow, my patient's not doing very well. What am I going to do? Right? It's so much easier to plan for the lower end and then progress to the higher capabilities than the other way around, because that's where we start getting in trouble. So, really eliminate. I rearrange every single person's house when I go in there. All right, hey, we're going to do some walking, but first I got to move the kitchen table. I got to move this chair. We're going to put the dog in the other room because I don't want them getting excited that we're walking around. I'm going to move this rug out of the way. I put it all back, but that is my first thing. My first 10 minutes is usually making sure the area is set up. So we'll look at that in a little bit more when we get our hands on stuff. Instructing our patient, important. Confirming the device setup is really important. And making not only the heights, we looked at a little bit of the how do we fit the assistive device to the patient last time, but making sure all the nuts and bolts are tight. It's so common where we look and we say, oh wow, this is very loose. If one little hit on this and it's going to fall apart. One other thing that can be really important is examining the tips of the devices. So that's the tips that come in contact with the ground there. And making sure that it's not slick when it touches the ground, because that now we're just adding to a problem. So those can become faulty really quickly. Is that going to fall, Addy? You think? I think it's going. You think? It's going. Nope. Hey, all right. An exciting morning we're having. Oh, I thought we had it. Nice catch. So the next thing is applying our gait belt, making sure that our gait belt is usable. We've played with gait belts a lot. A couple of things I am critical, or I have some criticism on. I personally don't like it when the gait belt is around the diaphragm. One, it's uncomfortable. Two, it makes it harder to breathe. And when we're going to be doing some walking activities with our patients, they need to be able to breathe. It also, when it is loose, we all saw once we stand up, that gait belt is now loose. If it is loose, now it can slip up even further. So I prefer having it right over the lower abdomen, and then tightening up as soon as we stand up. When our patient is standing with it, we should have to kind of force our hands in there. That's how tight it should be. It shouldn't just be easy to grip on. We should have to kind of wiggle our fingers in it. We always use what position do we make sure our palm is when we're holding onto the gait belt? Palm up always. So making sure that our gait belt is appropriately placed on the patient and tight enough that we can actually use it. Make sure your patient is performing the selected gait pattern, mental and physical. We'll look at that in a little bit. So just like everything else we do, tell, show, do. We're going to walk. This is the pattern we're going to use. Here's what it looks like. Repeat back to me. What do you think we're going to do? Okay, let's try it. And then most of the time, we're going to be two-handed guarding our patient, one hand on the gait belt, the other probably on their shoulder girdle is the next best. Sometimes we'll need both hands on our gait belt. We'll start looking at that. What side of the patient do we bias on when we're guarding our patient? Their impaired side, whatever the involved side is, that's the side that we guard to. Makes things a lot of things it's easy to just do on paper, and then when you come to people's homes like I do, you look and say like, all right, well, they've got a left-sided problem, but all of their furniture is also on the left side of the room, so I have to be able to move around, or maybe we go somewhere else to do this. So but if we can, and then making sure you maintain your proper body mechanics as well. Proper footwear for the patient, monitoring the patient's physiological responses, avoid grasping patients' limbs or clothing to guard. I can't tell you how many times I see people guarding with belt loops. What's going to happen if something goes wrong grabbing onto the belt loop? It's going to rip, and we're not actually guarding the patient. And then what also is going to happen to us if we're using the gait belt? The belt loop. Our fingers are going to be mangled. And guess what? You got notes to type after they fall. So it's not a good recipe. So, yeah, that's not great to use. Also, the grabbing the patient's limbs. We often see other caregivers doing it, grabbing kind of arm in arm sometimes grabbing underneath the shoulder girdle. Recipe for more problems. Big thing I can tell you is anticipate your problems. Either patient problems, they have a history, they're on a new blood pressure medicine. I don't know if they're going to get dizzy or not. Okay, how do we prevent that from happening? And then what is our exit plan when they do get dizzy? Maybe equipment issues. So being able to anticipate the problems solves a lot of them, because then we can modify the environment, or at least be aware to have an exit plan. We just talked about where do we stand. Do not leave patient unattended when standing. Boy, I was feeling angry about that, I guess. All caps. Yeah, I'm sure. I'm surprised it's not bold and underlined and italicized too. So, but this can be it's so easy to get up, start doing something, then look and say like, oh, I forgot the rug. And then say, hold on, don't move. And then go try to take care of the rug that's in your way. Or, the stool that was left out by another therapist in the clinic, or whatever else it might be. What do we do? If our patient if we're doing gait training with our patient, by definition, they are unsafe walking and standing. So that is a huge high risk activity when we leave our patient standing. What do? Sit them back down. Yeah, just like we did that with our bed mobility and transfers. You start to work with somebody, realize you forgot something. Okay, start all over. We got to do this again. Other things that can be complicated are patient appliances, casts, external fixators, catheter tubes, other lines coming out of the patient. That's always something to take care of. The area that's free of hazards, all of that is really important. So we already talked about this a little bit. Hand on the gait belt, palm up, other hand probably on the shoulder girdle. Sometimes you'll want to move it to the pelvis. Sometimes you want two hands on the gait belt. I don't know exactly, because we don't know exact size of the patient. We also don't know what are you doing there. If we're doing stairs, it's really hard for me to control the gait belt and the shoulder on a tall patient that's ascending stairs and I'm lower level than them. So you'll have to make some of those adjustments, but you should always have two hands on the patient. Posterior and bias towards the involved side. Maintain an anterior posterior stance at all times. We'll look at really how important that is. And avoiding cross steps. Always have one foot trailing the other. So we're going to be taking short, choppy steps when we're walking with our patient. We're not going to be using our normal gait pattern. And we're definitely not, if we're on the side, we're definitely not going to be crossing our foot behind our stance leg either. So why don't we do this? Let's wake up a little bit. Let's grab gait belts. Let's guard patients. Let's take a walk guarding our patients. Let's go all around this room, in and out of doorways. We've got stairs, either stairs in the main stairs out there. We've got stairs to nowhere in that room. Let's just take 10 minutes walking and guarding and just feeling okay with that. Okay? Any of that challenging? Made you think? Who, when they started ambulating with their patient, had a plan? Everybody just got up and said, let's walk around, right? Yeah, that's okay. It's so easy to do that. And it's so easy to take 3 steps and you go, oh my God, I can't believe this is going so poorly. What do we do now? So part of the setup should be, what is your plan? What are your exit points? So when I walk with my patients, my setup is I'm going to move the kitchen table over here, because if we can walk it to, if we make it there, we'll be able to just sit right down. We also have, I have the wheelchair over there. I have the couch over there. I've got this, I've got the bed right there. Like I'm finding my exit points all along the way. And also, if my goal is to walk across the room to the recliner, even if we're doing well, that's where we're going. I'm not deviating from that. I am going to sit down. We're going to talk about what happened. We're going to see how they're feeling. And if everything's then good, then we can say, okay, I can do a lot more with this person. So, so really making sure that you have that plan in place is so important. I don't want to be absolute in saying don't change the plan halfway through. Well, let me put it to you this way. In my mind, I always have the, if this goes well, I'm going to do this. So maybe we just do a lap and instead of just right to there. But if I don't have that plan already where we're going to go, then I am uncomfortable saying, let's do more, because I don't know what we're doing. Now we're into the unknown. If I clear the living room to do walking with my patients and I say, wow, you're doing really great, let's go to the kitchen. I don't know what hazards are in the kitchen. I don't know how big it is. I don't know if I fit and the patient. Is it small? Is it big? Is there something? Is there a trip hazard there? I don't know any of that stuff without making sure I have that plan. So I'm not going to say absolute don't change. I think as you're a student and a young practitioner, you shouldn't be changing things on the fly like that. You should be really strict in keeping inside of your plan and being able to change it once you say, okay, let's sit down, let's think, how do you feel? I think we can do a lot more too. Okay, how about this? So, yeah, Tony, do you have something?
Sometimes you have to think about if an emergency arises.
Right,
Yeah. Yeah. Yep.
Because you don't want to say that. Oh, no, we gotta make it to the lounge chair. You can't sit down yet.
Right. Yeah. So, not forcing the patient, but also having our exit points. If the lounge chair is too far away, then that's where our mistake was, is not planning that exit plan earlier on. And you're going to quickly learn your patient's abilities within the first few steps. You're going to have a good feeling of what they can and can't do. All right, so other things that we could use, these aren't necessarily assisted devices, but they can be helpful with gait training and preparing for gait. So parallel bars, tilt tables, suspension system, anti-gravity treadmills. So parallel bars, if you walk to the other room, we took those out, dusted those off. So these are really great because they provide maximal stability. Big, heavy, got a short runway. We got both hands available to us. The parallel bars aren't, if they're well made, they're not moving. Different than all of the other assisted devices. gives a lot of stability, requires the least amount of coordination. We can put chairs there. The therapist can guard within the parallel bars. So it's really nice when we don't know what to expect of our patient. Starting with the parallel bars is often a really great way to do that. So in order to fit the parallel bars, we want to adjust the height to allow roughly 20 to 25 degrees of elbow flexion. Approximately 6 inches in front of the hips. So when our hands are grabbing the bars, approximately 6 inches anterior to our hips. That's what the patient position should be. We can estimate by adjusting the bars so the top of the bar is even with the patient's greater trochanter or ulnar styloid when the patient's upright with the limb by their side. That's actually the same for all of our assisted devices. Have the patient stand up, arms by their sides. Ulnar styloid and greater trochanter should be about the same. We adjust the hand piece to that height, and then we go from there. Some people have really long arms, and their greater trochanters don't line up with their ulnar styloid, and you have to make your best judgment on what that looks like. And getting your patient's feedback. I don't know if you feel differently, Tony. I feel like all of my patients are always between 2 notches. There's never one person you go, wow, you're perfectly on this notch. So if we could go higher, we could go low, we have to choose one. I put it in my patient's hands. We take a few steps, change it to the other notch, take a few more steps, which one feels better to you. You also will have that, just like with the positioning in bed, when we put all the pillows, you just step back and say, does this look about right? You'll have that ability to do that with this device. I know you like it low. I just don't think I think the higher is the way you look better with this. So you have that, some of that clinical judgment as well. So that's how we adjust the height. We also need to accommodate the width. So approximately 2 inches wider than the patient's width at the greater trochanters. We should be able to pass through unobstructed. So that's the big thing for that. We have to accommodate for the width with the parallel bars. Tilt tables. Tilt tables are really cool. I really only see them in hospitals. I don't see them in a lot of other places. Really great for patients who have not been upright for an extended period of time. Patients where they're really great for is when there's orthostatic hypotension or other blood pressure problems. Then we so what a tilt table is, the patient is on the table similar to this. It's got a big heavy foot plate on it, and then the patient gets strapped down to it, and we get to either crank or with electric tilt the table against gravity. So the patient goes from horizontal to upright. Really great for patients who have blood pressure concerns. That way we can say, okay, at 30 degrees, their blood pressure dropped now. 6 weeks later, they're at 50 degrees, whatever. So really great for those people. There are others, different brain stents to help flow of the cerebrospinal fluid. Those can cause a lot of problems, and we can use a tilt table to get the patient used to that. Vertigo is a common problem that we get to use a tilt table for. So tilt tables are pretty cool. Really only see them in hospitals, but I don't know if you've talked to the last group that just took their licensure exam. I had a few people tell me there's so many questions on tilt table. There's probably 2 questions on tilt table, but they said it felt like a lot. So
Yeah, I heard that came up with prior to that also, and there is a nice video Sullivan and Smith
on tilt tables, yeah, yep. Anyway, so elevation can go up to roughly 70 to 80 degrees for 15 to 20 minutes is the typical session for what a tilt table, how you'd use it. Could range for 5 to 10 minutes to over 1 hour, a couple times a day. We don't have our patients go up to full 90 degrees, up to full upright, just because that's a fall risk to fall out of that table. Especially if they have if that patient has a lot of anterior weight to it. Now we're worried of maybe the patient doesn't fall out of the table. Maybe they bring the whole table on top of them. So we always like to have just a little bit of incline to it. Other things, a bunch of different suspension systems that we could use. Some are mobile, so they're on wheels, and the patient can be harnessed, and then they can walk around with this big contraption. Others have track systems that we could install too. I see these being sold a bunch. I don't think I've ever seen one in person. They're pretty expensive. And in order to spend that kind of money, you would need to be in a specialty population that's going to require that, which is mostly pediatrics. Well, pediatrics, small, we can have a smaller system for them. Or the other is heavy post-stroke and TBI related problems. If you have a heavy neurological clinic, then that could be something that you could use. Yeah, maybe. I'll show you one other thing that I'll show you. Remind me of spinal cord injury. I'll pull that up in a minute. So anyway, there are different harnesses with suspension that can help the patient, and those are really good for us because now I don't have to guard. I just have to make sure the harness is on. That's pretty nice. Others, the Ultra G treadmills. I only know of one in the state that's at the Pawtucket High Bar. Do you know of any others off the chance? So it's still not used a whole lot, but pretty cool. Patient stands, a gasket basically goes around them, pump a bunch of air, and that unweights the patient. So that's pretty cool. All right, so let's start looking at assistive devices. So I don't want to, we'll just pick one at a time. I want to use more thinking than just me lecturing. So the big things we have to consider: energy requirement, stability, weight bearing status, and other pros and cons will be the next thing. So we're going to start with walkers. We have a few different types of walkers. So first up is this walker here. All right, this is what we call, this is just a standard walker. So tell me, energy expenditure, low, medium, or high? High energy expenditure. One, this standard walker doesn't have wheels to it. So in order to take a step, we need to lift it off the ground. So that's a lot right now. Also, in terms of assistive devices, pretty heavy. Might not be heavy for anybody in this room, but if we start thinking about what are the types of patients that are going to be using this for, this is a good amount of weight. So high energy expenditure. What do you think of stability? Pretty stable. Yeah, I would say high in terms of stability. Weight bearing statuses. How many different? First of all, what are the different weight bearing statuses? Full weight bearing, great. Partial weight bearing. Describe partial to me. Stumped you already? Come on. Not your entire limb, not your entire weight on one limb. Yep. Now, just saying partial to me, like if I ever read an order that said partial weight bearing, what are you talking about here? So usually when we have a partial weight bearing status, there's either a poundage or a percent body weight that goes along with it. I've had protocols where it says, okay, week one, okay, we've been non-weight bearing for X amount of weeks. Week one weight bearing, you're at 30% body weight and progress 10% each week until full. Okay, great. I know exactly what to do. I've had others that say allowed 50 pounds weight bearing. All right, that's okay. I can do it. What I will say, the best teaching device to teach our patients what partial is, and again, partial, there's a wide range of what, anywhere from 1% to 99% of body weight is partial. So teaching our patient what that feels like is really difficult. The best tool that I have and I have one in my car, is the analog scales. So analog bathroom scales. Digital doesn't work because it takes a lot of time to read the digital weight, where the analog, we can say, oh, you went high, you can put a little bit more on that. That's the way we can teach our patient that proprioceptive feeling of what 20 pounds, 30 pounds, 80 pounds, what that feels like. All right, so that's partial. What other types of weight bearing do we have? Go ahead, Brent.
So there's weight bearing as tolerated.
Oh, weight bearing as tolerated. That's a good one. So what does that mean?
Well, that's
Yes. Yes. Partial weight bearing is an exact prescribed poundage or percent body weight. Weight bearing as tolerated means what? Whatever the patient can do is what we should be doing. And our goal is to progress the patient along with what they can tolerate. We should try to figure out why they can't tolerate it, and then our treatments improve that. Pain, and then strength are the two big ones. So yeah, we have weight bearing is tolerated versus partial weight bearing. Great question.
for partial weight bearing. I know you can measure the analog, but they didn't go. It's just like an honor system, if you know your patient is.
Yeah, and yes, when we're trying to teach our patient, we are very strict in how they can do it. And my advice to them is always, listen, you're not going to screw something up if you go less than this pounds. If you go more than these pounds, doc, I'd rather you err on the side of caution. I'd rather you be too light than too low. But why would they have a prescribed weight bearing percentage? Why would some docs say you're allowed partial weight bearing? So the call, yep. Wow, perfect. Look at that. Look at these. All right, so if you haven't ever seen an analog scale, this is what it looks like, right? We put it, and this one is so colorful. Pretty great. Yeah, I'd like to see Gonzo's feet fit on this. I'm not sure that's gonna work well. So yes, so going back to why would we have a partial weight bearing status? Yes, you're talking about diagnosis, but why doesn't the surgeon just say be non-weight bearing until 8 weeks, till the fracture is 100% healed or the surgery 100% healed? Like, why not just wait all that time? Great thought. What else? So weight bearing can improve healing depending on what the problem is. I use fracture as an example. Fractures, we wait until it's healed. That's so it can improve healing in some ways. We're also minimizing we're preventing secondary complications. So preserving muscle mass, all of that is important. Also eliminating or preventing contractures, right? So if I just had my leg like this for 8 or 10 weeks, and then I go sit down, I could be developing hip and knee flexion contractures. So yep, that's a good thing. Any other reasons? Improved independence. Yep. Any other reasons? Yeah. So, and we're preventing additional decline. And when we get to start normalizing the gait pattern, all other things are helpful. My arms hurt when I am non-weight bearing because I have to use my arms to walk now. This side hurts because I have to use this side 100% of the time and not the portion that it's used to. So the more we can normalize gait mechanics, everything else is better. My back hurts when I walk like this, not because I'm doing anything crazy with my back, but I'm not using my body like it's designed to. So yes, normalizing gait mechanics is something we're going to be doing as soon as we possibly can. All right, so that's partial weight bearing versus weight bearing is tolerated. We also did full weight bearing. What other weight bearings do we have? Toe touch. I love toe touch. What's that mean? Just put your toe on the ground. Yeah, yeah. And what are some ways we teach our patient what toe touch means? Because when I first tell my patients they can be toe touch, or their doc said they can be toe touch weight bearing, and then I see them 2 days later and to watch how they're moving, they are not toe touch. They're walking. So how do we teach our patients how much pressure that can be? Because I have patients walking like this, like, no, it's just my toe. So what do we teach them? How much pressure is that? It's just for balance. All you're doing is you're just putting it down just so you have a little bit of balance. It's the only thing we're doing. And if there's a grape underneath your toe, the grape should stay intact. Like that's what toe touch is. Don't squish the grapes. Use whatever fruit you want. But that's what it is. So when we start teaching our patients, that's what toe touch is. It's not you can weight bear fully through your toe. It's no. It's only there to help you with balance. So any others? Non. Yeah, that was the last one I was thinking of. Non-weight bearing, right? So you do not put that foot down whatsoever. All right, so that was weight bearing. So what weight bearing statuses can we use with standard walker? All of them. All of them. Yep, all of them. All right, so we've got high energy requirement, high stability, broad spectrum of weight bearing statuses. What other pros and cons of, let's stick with the standard walker for now. I think might not fit in an area of their house, might not fit in their environment is a huge problem because it's so easy at the doctor's office to say, oh, you fell? I watched you walk. All right, here's a walker. But the walker does not fit in the person's house. That is a very common problem that I encounter. Yeah, I've got the walker, but it's out on the porch because it doesn't fit in the house so I can use it. Yes, huge problem. Yep. Any others? What was it? Heavy. Yep. What else? Absolutely. Stairs are a big problem with walkers. Yep. Gait speed decreases significantly. Yep. Any others? Yep, I think that's a consideration, and you know, for our patients who have altered weight bearing for a little while, that's another reason why partial weight bearing or weight bearing as tolerated is so important, is because we want to get rid of the device as fast as possible. Some of our patients are the opposite end of the spectrum, where we want them to use this for the rest of their life to prevent falls or other problems. Cosmetic, definitely. Yep. Any others? Hassle to bring it everywhere. Yeah. How are we going to get this in and out of the car? And especially if our patients are driving independently still. Yeah, how are they going to do that? The dance of, well, this fits in the back seat, so I have to fold this up. I put it in the back seat. And then I have to shut the door, walk to the other door to open it up, and then get in my. That is one of the highest fall risk activities for my patients who require walkers for ambulation because of balance. It's that whole circus of how do I get this actually in the car? Tough to transport. I'm sure there's others that we'll look at the slides in a minute and talk about, but I just want to talk briefly. Compare it to the rolling walker. We've got just the front wheels on this one. I also put the platform on this. So we talked about the platform a little bit. The platform, great for when we're non-weight bearing on a side. So, I mean, how often do you think this happens? I use a walker for balance, but I fell and broke my wrist. How frequent is that? Do you think that's a common problem or a rare problem? Fairly common. So we can get to use one of these platforms so that the patient can still use their walker without being weight bearing through their what would be non-weight bearing wrist. So pretty cool. Big thing about these is they will need constant adjustment. They need constant tightening, and we'll fit this. This whole walker is a little low for me, but we'll fit it all perfectly. And then after 2 days of walking, everything is going to need to be readjusted because everything loosened up and it just sank, and now we've got to fix it all. But that's what the platform looks like. Rolling walker versus standard walker. Pros, what do you think? Increased speed. Why is it increased speed? I don't have to lift it up every single step. Yep. And what do you think, con? A con could be increased speed. Yeah, for some of our patients, we want to slow them down. Yeah. Stability. Give me more details you think on that.
Versus this, you could just sort of continue to go forward if you don't want to.
Yeah, because of the wheels, now that is, yes, especially on slopes, we can have this continue to either accelerate us, or if we stop and just let go for a minute, it might just keep rolling. So yes, that's.
And people are probably less cautious about thresholds and carpets and stuff. They try to go through them and.
Yeah, thresholds and carpets, thinking we could just drive over everything. Yeah, yep. So really good. We also, I won't go over it too much, but we have our hemi walker, or a one-handed walker. What patients would require a hemi walker? Tell me, say it loud. Someone who can't use this arm. They can't use a two-handed device because either this hand doesn't exist or it's non-functional, right? So the most common is stroke. That's where this arm is spastic and stuck. I have some gait ability, but I need a heavy device. I need lots of stability to help me. This would be what we would do that. Also, big thing for this, flat side goes towards the patient. I wouldn't want to use it like this because now the legs of the hemi walker become the trip hazard. So we teach our patient flat side goes against them. All right, so those are our walkers. Let's see what other stuff we might have missed. All right, so difficult to store and transport. We talked about difficult on stairs, reduced speed. Gait patterns, more difficult to have a normalized gait pattern. What is a normalized gait pattern? I mean, we've got a bunch of subphases to it, but I think what I'm referring to mostly here is the reciprocal arm and leg swing. Can't really do that with a two-handed device like a walker. Difficult to use in crowded areas, whether that's crowded with things like in a home or crowded with people. Other types of walkers include a posterior walker, upright walker. I have never seen a reciprocal walker. There's some sort of hinge. I even tried to find a picture of one and I couldn't last year. There's a hinge in the middle that allows a more normalized gait pattern. So that's pretty cool. Have you ever seen one of those? I've never even, but hey, great. There's also stair climbing walkers, another one that I've never seen before. And yeah, man, if stairs are part of this person's life, are we really comfortable with giving them any type of walker? I'll try to look up what a stair walker. Yeah, right. So there's pros and cons of every single type of these walkers. So sometimes the cons outweighs the pros. And then bariatric. The bariatric ones are just a lot wider. All right, next up I want to talk about these axillary crutches. So here we go. Here's axillary crutches. Let's think Energy requirement, high, moderate, or low? I think, all right, so I think high is a good answer. Compare it to walkers, more or less than walkers. Probably less than a walker, but still high. So yeah, I think that's the right answer. Stability, not as good as a walker, but we've got two hands to it. So what are your concerns with stability here? Is it with the device itself or the user of the device? So the user of the device is the thing we have to really consider, because these can be very stable. We got 2 points of contact. They're out nice and wide. It can be pretty stable. There's 2 points of contact with me, one in my hands, the other rests against my ribs. So that, there's a lot of stability with this, not as much as a walker, but the user we now have to be really careful with. Can grandma use a walker? Yeah. Can grandma use crutches? If grandma plays tennis 3 times a week, then she probably could use crutches, but most grandmas aren't going to be using this. Weight bearing status, what do you think? So ranging from non, toe touch, partial, as tolerated, full, all of them, right? No issues. We could use any type of gait pattern that we need to, or with a variety of weight status. Other pros and cons of axillary crutches. One big con that we talked about, who had these crutches before? Was it Tate had them? What was the big problem with how Tate was using it? Too high. So what's the problem with having it too high? Skin breakdown potentially, but there's one other big concern. So we could have poor posture. There's one other big concern. You guys ever hear of crutch palsy? So that is where, what's the nerve that goes to the serratus? So that is where we crush that nerve so much that it creates, we would end up with scapular winging because we've crushed the nerve that feeds the serratus. So that's why when we see our college kids and our high school kids walk like standing like this, or if it's just malaligned and poor measured, that we are going to have a big problem with that. Also known as Saturday night palsy. Do you guys know why it's called Saturday night palsy? Because when and this wouldn't happen to any of us, but after having 1 or 6 too many, ended up falling asleep like something like this. And then there you go. You wake up in the morning and go, geez, my shoulder blade is sticking way out here. And I got a slamming headache. So yeah, that's the other common mechanism for that, but mostly crutch palsy. So that's the big concern is making sure that the axillary crutches have the appropriate space in between the floor of the axilla and the actual axillary pad here. All right, what other pros and cons do you think we have of these? Might need one. Yeah, so I could maybe I could have 2, maybe I only need 1. Great thought. Absolutely. Way more mobile. Tight spaces, what do you think? A little bit better because I can adjust. I can walk sideways. I can do a lot of things with these that I don't have available to me with the walker. I think these are really good for stairs. We'll learn how to do it. But again, that's a user thought process. The crutches themselves are really good with stairs. Yeah. Yep. Any others? Any other pros and cons? Let's see what we missed.
Just, with the walker because you're going slower, because it's got 4 points of contact on the ground, and everything's sort of fixed in place. I think you just placement of the crutches need to be more aware of your surroundings. That's it.
Yeah. So yeah, I love that thought process. I mean, with the walker, there's a huge frame. It's all attached to one. These are independent of one another, so being aware of our surroundings is a good thought to it. You could, yeah, just put a little snow plow in the front of it and clean it all up, right? Let's see, where was I?
I think for a walker, you still need functional strength for your upper extremity.
We're gonna need upper extremity strength for all of these. How much upper extremity strength we need will be more reliant on their weight bearing status than the device. But yes, with altered weight bearing status, we're gonna be needing a lot of arm. So actually, crutches, greater selection of gait patterns. Just like when with the walker, we said that it's fixed. We don't have reciprocal trunk motion. If our weight bearing status and everything else checks out, I could have reciprocal. I could have a more normalized gait pattern. We'll look at all those gait patterns later. Definitely less stable than a walker, which we identified. Axillaries we talked about requires some good balance and coordination. And functional strength of the trunk as well as the upper extremities required as well. Compare the Canadian crutches. So these are Canadian crutches or forearm crutches or loft strand. So first off, just like with the axillary crutches, we were concerned with skin and nerve integrity of my axilla. What is the big concern we have with these forearm crutches? The olecranon, making sure the cuff is far enough away from the olecranon, we're going to get skin breakdown there. Pros and cons of these, what do you think? They're a little bit less stable because they don't make contact to my trunk. They're only attached to my arms, so they're just slightly more unstable than the axillary crutches.
They're able to use their transverse ligaments or something.
To lean on. I'm not sure. I think that would be a highly individualized. Do you have any thoughts on that, Tony? Okay. Yeah, I think that would be an individual case by case, not necessarily a diagnosis thing. What other pros and cons do you think? Less bulky, yeah, yeah. I mean, there's just the length of them alone is, 10 inches smaller. So yeah. Yep. Did anybody? Yeah. Potentially, yeah. Yeah, I have a little bit of a fulcrum, so if things go wrong, potentially. Any others? Yes, these can stay attached to me while I stand at the counter. I can chop vegetables. I can grab a cup of coffee. They stay attached to me, whereas the axillary crutches have to be placed somewhere and they're going to end up on the ground. These have a chance to stay attached to me. Yep, good. I think so. That's a great point. These are more long term than the axillary crutches. That's a very American thing. I went to Italy for my honeymoon. This is not 9 years ago. Yeah, something like that. No, she doesn't watch these videos either. We went to Italy and everyone had Canadian crutches. I did not see an axillary crutch in the entire country. And not everybody had a long-term disability. So yeah, I think that's more of an American thing. But yes, you are right. In the United States, that is much different. I don't know what it's like in Canada, to tell you the truth. But Yes, in other parts of the country, these are the standard crutches and not the axillary crutches. Okay, let's see what we missed. I think the cosmetics, because we associate them with disability, long-term disability versus in the United States anyway.
Doesn't even say cosmetic, it says insecure.
Less stable, requires functional strength. Forearm cuff can make it difficult to remove crutch. That can be something. So, and then elderly feel insecure. That has to do with the stability of it, not emotionally insecure. We talked about platforms. So the platform attachment to the walker is what I showed you. We could have platform crutches as well. That's pretty. I don't know if I've ever seen platform crutches in the real world. Have seen platform walkers. Anyway, unable to either range of motion deficits or weight bearing ability restrictions. Loses disadvantages, loses triceps to elevate and maintain swing phase. Another person might need to help apply them. Less effective on stairs if they're crutches. And then the next thing, cane. Who wants to? So we've got a couple different versions of canes. Where's the one? We got this. Oh, both of them. So we got this quad cane versus the straight cane. Let's stick with the quad cane first. Energy requirement. Low, although the quad cane's more than the straight cane. Stability. So I think this now we're using a one-handed device, so the stability is less than any of the two-handed devices that we've used. So we're down towards the lower end, although the quad cane better than the straight cane. There's also small base and large base quad canes. So that's another factor. But yeah, stability, we're down towards the lower end of the scale. Weight bearing statuses. Full. Partial weight bearing is tolerated, definitely. And then partial depends on how much weight the person can actually weight bear through. Straight cane, about 12% body weight. We can offload 12% body weight into the cane. So yeah, we have to be pretty darn good with weight bearing. Other pros and cons. Let's stick with the quad cane for now. Pros and cons of the quad cane. It won't fall over. Yeah, we just leave it. It doesn't tip over versus straight cane. Yeah, it doesn't. It does have a specific side. So we want, just like with the Hemi walker, the flat side goes against the patient. Because if they use it this way, those prongs become the trip hazard. Yep. Any other pros and cons of the quad cane? Yep, you can do that. Yep. Fairly heavy and can be awkward. It can be tough to place all four prongs on the ground at the same time. So there's a decent learning curve to this. And especially if you have uneven ground, this works really well in level ground. Uneven ground, it has a really tough time because we have 4 different points of contact. Straight cane, pros and cons. Lightweight, fits anywhere, throw it. I mean, this can go right beside you. You get in the car, put this right between the door and you, and you're good to go. Piece of cake. Yep. Say that again. Tell me how you think you would use that with extension of themselves. Tell me what you mean. Get out of my way. You've been on stage long enough. Yeah, all of that. Yeah, absolutely. Yep. Get to shaking at kids on the lawn. Yeah. Yep. Yeah. Any others? Did you have something else? If our patients are using a straight cane, they have to be able to pick it up off the ground because it will 100% end up on the ground. We'll teach some ways we can think about that, but it will happen.
I think she dropped that. She was kind of bent over, like, and her bush was on the floor, and she was falling over, and I caught her. Kind of got upset. I don't know why, but she said she. I don't know if she dropped her finger.
You're a hero, Lexi. You saved somebody. You saved somebody at Stop and Shop. Don't get those kind of troubles at Whole Foods. I'll tell you that. All right, so let's think about this. So great job catching somebody. Let's think about this. So Lexi came upon somebody. Cane was on the floor. Groceries on the floor. Lexi grabbed her, so she didn't end up on the floor. And the person says, "What are you doing?" Is that person mad at Lexi? What they're mad at? They didn't want to fall, right? They're embarrassed. Her grapes are everywhere, right? So yeah, so she was not mad at you for helping her. She was mad that she needed help. It's a good thing you were there and you did provide help. Yeah. But yes, canes will land, straight canes will land on the ground. So our patients, why are we giving somebody a cane? Because they have some sort of gait need. But we also have to get them to a point where they can pick up the cane off of the ground. So that's tough for us to do, but definitely something. All right, let's see if we missed anything.
Probably have to have a little bit of balance.
So good for impaired balance. Definitely more useful in narrow areas. Stairs, something we didn't talk about. Stairs, what do you think with straight canes? Stairs with straight canes, pretty good. Quad canes can be a little bit more challenging, especially the small base quad canes. We can do okay. The large base quad canes are a lot more challenging. In order to use it, when we do stairs, we'll look at it. We turn them sideways so it fits on the stair. So we'll look at that down the road. So limited weight bearing, smaller support, limited support. So definitely on the low end of the stability. Another type of cane that I don't have is the hurricane. You guys know what that is? It's I think with documentation we refer to it as a small base quad cane. It's got basically it's like a little disc with 3 little prongs to it, and that bottom isn't firm. It's not firmly secure. It has a little bit of wiggle room for that. So those are really good for uneven ground. And they don't fall over as frequently. They still will, but they don't fall over as frequently.
And there's their problem with canes also.
You think? What do those look like? You think that's a marketing thing? Is does the cane climb stairs itself?
No.
Is it like in Fantasia where it grows limbs and it's
No. You can step on top of it. It's got a flat.
oh, yes. So the stair canes, it's a small platform that's attached to the cane. And what that does, it cuts the height of the stair in half. So we get to step up, put the platform, the stair cane on the step on that, and then the next step is half the distance. So it is. And actually that 103-year-old that we got to walk into church, that's what she had to use because she didn't want to use the stair lift at church. She had to use the stairs because she didn't want to look like the old lady. She did it. She amazed me. Anyway, so fitting assisted devices. Like we talked about with the parallel bars, I think we briefly mentioned it last week. Fitting the assisted device, the handpiece should, our patient stands their arms by their sides. The handpiece is going to land ulnar styloid / greater trochanter, once that we place it in their hand, we need about 20 to 25 degrees of elbow flexion. Why is that so important? 20 to 25 degrees elbow flexion.
Here, the brain.
Muscles are at mid-range when we do that. So we're not fully elongated, we're not too shortened. Yeah, we're going to be able to really generate a lot of power with our arms in that position. So if the patient has structural deformities, example, they're stuck in trunk flexion, we then modify the assisted device to accommodate that. So many people come to me and say, Josh, I'm walking too far hunched over. I want to use a walker, so it forces me to go there. Well, we can fix your posture. We can improve upon that. If we try to do this with the assisted device, we're going to increase your risk of fall because you're used to walking hunched over like this. If all of a sudden we had you walk like this, your center of mass is now completely different than where it's been for a long time, and you're going to have a big risk of falling. So posture is a separate problem that we have to slowly attack rather than just saying, oh, let's just fix it all at once. So other things with fitting, and once we go through this, we'll have you fit each assisted device with each other. So the rear tips of the walker should be at midpoint of the shoes. So I should be midpoint of my feet should be at the rear legs. Axillary crutches, the tips of the crutches should be 2 inches lateral and 4 to 6 inches anterior of the shoes, or the toes of the shoes. Height of the crutches should allow a 2-inch space at the axillary floor. So 3 to 4 finger breadths between axillary floor and the axillary pad. Forearm crutches. Now we're going to be at least 1 inch to 1.5 inches below the olecranon for that cuff. Canes. We looked at weight bearing statuses. So here's what I want to try next. We've got a whole wall of assisted devices. We've got other walkers in that room right there. So what I want you to do now is we have walkers, axillary crutches, Canadian crutches, and canes. Those 4 assisted devices, we need to practice measuring and then fitting it appropriately to our patients, which are you guys, okay? All right, so let's spend a lot of time just messing around with this stuff. All right, so 2 just little tips that I'll show you. If we need a lot of adjustment with our devices, one of the things that's always helpful is you could do every single notch pushing these in, or you can spin just slightly, and then you get to move a bunch at once. Don't spin it so much that you can't see those push pins because you want to know where to stop. But that's a simple little thing just to twist that just a little bit. That way you can really slide up and down a lot of notches. The other thing I wanted to show you, can I have that walker, Morgan? This is your clinical judgment thing. You see how the wheels are on the outside of this? For my patients in a narrower house, I put the wheels on the insides because it gives about 3 to ish inches of clearance. So if the walker won't fit through the bathroom door, sometimes we swap the wheels to the insides and all of a sudden it fits. So that can be really helpful. Con of putting the wheels on the insides. I'm not concerned of trip hazard. I don't have patients that are walking so close to this that my patients walk with their walker way away from them. So I'm not concerned of trip hazard. It is, if we took away 3 inches of width, we did make the base of support slightly smaller. So some patients do need that level of support. So, how did fitting everything feel? Any major problems? Starts to make sense a little bit. All right, so let's do this. Let's take 10 minutes and then we'll start learning gait patterns and then we'll start working with which devices will fit with which gait patterns, okay? All right, so the next thing we're going to go over are the basic gait patterns for a variety of assisted devices. The number one thing we have to consider with which gait pattern would be most appropriate is the weight bearing status of the patient. Other things to consider is this going to be a long-term gait pattern or a short-term? And we want to normalize the gait pattern as much as possible. So we've got a few different gait patterns to learn, and we'll look at who gets what. So first up is a 4-point gait pattern. Actually, Abby did this one. I was shocked he did it. So 4-point gait pattern means I have bilateral assisted devices, either crutches or canes. And each one is going to hit the ground at different times. So I'm going to go assisted device, contralateral lower limb, assisted device, contralateral lower limb. 1, 2, 3, 4. 1, 2, 3, 4. Okay. So this is my 4-point gait pattern. Again, we need at least bilateral crutches or canes to do this. Very stable, good for crowded areas, but it's slow, requires lots of energy expenditure, requires lots of coordination. Really good to increase base of support. It's also similar to, not exactly, but similar to our normalized gait pattern of reciprocal arm swing. Good for balance coordinations, but really decreased coordination, diminished speed. We're only going to select this 4-point gait pattern for someone who needs bilateral assisted devices, and they're going to have this type of gait pattern for a long period of time. How much time do you think it's going to take for us to teach our patient crutch, step, crutch, step? I get in a little bit, we're going to practice all of these. You guys tell me how easy it is for you to learn all of this. It is tough. So we only teach this one. This one's really for a long period of time. This is the gait pattern you're going to need forever. I've seen a gait pattern, this 4-point gait pattern, maybe 2 or 3 times in my life. And none of them were my patients. It was just, walking around in Vegas or somewhere and saying like, whoa, hey babe, look across the street. That's a 4-point gait pattern right there. Like, that's the only time I've ever seen it. Have you ever seen it as a clinician?
Yes.
Oh, yeah. Oh, okay. Yep. Yeah. Yeah, that's a good strategy. Yeah. Yeah. So, because of the high energy expenditure, big learning curve to do this well, this is really like, okay, you really need this gait pattern. I'll show you one example. 2-point gait patterns, same thing. We're going to use bilateral assisted devices, either crutches or canes. But now we get to really approximate that normalized gait pattern. The assisted device and the limb get to move at the same time. So it's crutch and foot get to go at the same time, or cane and foot. So really good. Pretty stable, a lot faster than the 4-point gait pattern, relatively low energy expenditure, very similar to the normalized gait pattern, which is great. But it is less stable and still does require coordination for that one. So that's our 2-point gait pattern. Modified 2 and 4 point gait patterns. We need. This is not appropriate for partial weight bearing. So what the modified is, we just get rid of one assisted device. So we only have it in one. So the modified 4. Left, right, assisted device. Left, right, assisted device. The modified 2 will be right, crutch and assisted device. Right, crutch and assisted device in the foot. Now, I already told some of you, but let's do this. If I'm walking like this, what's my involved side? So my left side is my involved side. How do you know that? Because you want the assisted device opposite side of the impairment. Does that make sense to everybody? You guys know why that's the case? Why do we put the assisted device opposite of the? It shifts my weight away from that problem side. So even if I'm weight bearing a lot through the assisted device, in order to use this, I have to shift weight towards the problem side. If anything goes wrong with the assisted device, I've got all of my body weight on that side. What's the other? Any other reasons? Coordination, a little bit. It's normalized gait pattern. Right. So if I were to use my assisted device on the same side, I have to walk, like this. Right. That's not reciprocal arm swing versus if it's in the opposite side, I get to have that reciprocal arm swing. Does that make sense? All right. So we use the assisted device placed into the hand opposite of the effective lower extremity. There's our modified 4 and a modified 2. So we also have a 3-point non-weight bearing. We can use crutches or walker. We cannot use canes because we can't be non-weight bearing with canes. But 3-point non-weight bearing, we can either have a step 2 or a step through gait pattern. Step through or step 2 is referring to, do I meet my stance leg? Or where the back feet of the crutches are, or do I step through that line where now I'm coming all the way through? So this is step through. I'm crossing that line in between the back legs of the walker, or step 2 as I go to that line. Step 2, step through. Which one do you think we'd like to progress our patient to? Which one is the better one? Step through, why? Faster, lower energy expenditure. Right, did you say something else, Laura? Yeah, cover more distance, less amount of time. So it is a little bit less stable than other patterns, but allows that faster ambulation speed, high energy expenditure because we're weight bearing through our arms. I got to lift up and advance the walker somehow. So very high energy expenditure. Is it going to happen again, Addie? Definitely need to have adequate arm strength in order to do that. Three and 1. This is a partial weight bearing where I'm going to advance my limb with the assisted device. And then I get to either step 2 or step through. Could potentially be used for toe touch weight bearing as well. Toe touch weight bearing, how much weight does the patient bear through their leg? Toe touch? That's weight bearing is tolerated. Toe touch is next to nothing. Not enough to crush a grape. So more stable than just a 3-point because we are putting that other limb into contact with the ground. That's what increases our stability of it. Depending on how much weight bearing we're allowed. It can reduce the strain on our upper extremities. So that's nice too. All right, so here's what I want to do. You have to be experts in all of these gait patterns in order to demonstrate it to our patients. So grab your assisted devices and you need to practice every single gait pattern until you can execute it really well. So it's going to take us at least 45 minutes to run through these all well, okay? All right, I want to talk about few things. We'll show sit to stand with these different assist devices. It's another layer that we should be thinking about. I did want to quickly demonstrate one thing. Would you mind standing here non-weight bearing? Stand grabbing that non-weight bearing. So textbook says I should be guarding where? Posterior lateral side, on which side? The involved side. So I should be here. That's what the textbook says. Although, because he's non-weight bearing, there are times in which I'm going to feel more comfortable guarding on this side because I can pull him onto his uninvolved side a lot easier. I can also visualize what should be non-weight bearing a lot easier than if I'm right here. It's hard for me to see straight down through his body, through his arms. Where over here, I can see that limb a lot better. So in the non-weight bearing scenario, you do have a choice which side you feel most comfortable guarding. Does that make sense to everybody? All right, thank you. Appreciate that. Yep.
Looking down when you're kind of like, it's gonna do a lot of this.
Yep. All right, so the last thing we'll cover for today, we'll talk about a couple other things that we've had some questions about. But last thing we'll cover is how to teach our patient to get up out of a chair with whatever assisted devices they're using. So, first step of getting up out of any chair is first up, slide to the edge of the chair, right? So that's going to bring my center of mass closer to my base of support. If I'm way out here, my center of mass is way outside of what's about to be my base of support. Also, it puts all my muscles in the appropriate position. So, in mid-range versus out here, I'm really far away from making that my mechanical advantage. If we have a stronger side, that stronger side can be closer to the patient. You can slide it back. That'll enable just a little bit more power coming off of that. It also increases my anterior posterior base of support, which once we're upright, that's only going to improve our patient's balance, having that just slightly bigger base of support. Hands on the armrest if they exist, slightly anterior to the hips, a little bit of trunk lean with that too. And then we say push, stand. Great. Okay, and then to sit down, we're going to do the reverse order. We're going to back up until that strong leg is touching the chair. They're going to reach the armrests. And then we're going to descend slowly with that forward trunk lean. Really focusing on the slow of descent is really important. Number one mechanism of injuries of older women is sitting in a chair to plopping in a chair. Compression fractures of the lumbar spine. That's the number one mechanism of fractures for older women. So we really have to cue our patients to slowly sit down. All right, so with a walker, preferred is what we want to do is place the walker in front of us, perform that sit to stand that we just talked about, lean forward, a little anterior, posterior, hands, push. And once we're upright, here's what the trick is. One hand goes to the walker. Once I'm in grasp, then the other hand goes. That way I'm always in contact with this something that's stable and I'm not letting go all at once, right? So in this moment, this is where the falls are going to happen. So we really want to emphasize that. Descending, same thing. Reach one hand back. Once you're in contact, then you reach the other hand back and then we sit down. So really breaking that up for our patients is going to be important. especially descending. Ascending, I have typically less problems with, but descending, I'm already starting to go down and I don't have contact with my hands and maybe I misjudged where the chair is. That's typically the danger spot in the descending. Alternate method is some of our patients are just going to go one hand on the walker, one hand on the chair, and that is okay as long as they're not really tugging on the walker, because it's not going to help them ascend. But sometimes you want it here just for stability, especially if it's a one with wheels on it and maybe we're on a slightly uneven surface. You know, you want to make sure that's held in place. So you could do it that way. I don't like doing it this way because even though I tell my patients, you know, push hard with your hand on push hard with your legs, don't pull on this, they all eventually do. So I personally don't like it. Some of our patients do feel better with it. So do you have any opinion on that?
No, I agree with, holding on to the wall and just hanging on it.
Yeah, yeah. Yep, take. Great question. If it doesn't have armrest, we got to ask our patient placed it. But they have the seat of the chair that they can push off of. So yeah, that's where it should be. All right, with crutches, a little trickier.
Start with the box.
Yeah. All right. So first off, I'm going to place both crutches in the hand opposite of the stronger foot. All right, so I pulled up my pant leg so you can see what my involved side is. So this is where we're going to be. We do all of those steps that we just did, except now I get to use this here. Some people, their hands aren't going to fit like this, and we're going to have to do like a cross so that my hands can just fit on one. Okay.
Just reading it.
Oh, opposite of the stronger foot. Is that what you were saying? Yeah. Yeah. Opposite of the stronger foot. Sorry. Yep. Thank you. So whichever way you want to do it, this cross section, because the smaller tubes fit my hand better, or both hands on the hand rests. You just have to play around with one yourself and then two, see what your patients like to do. But there we go. Boom, ascend. And then we get to place this appropriately. And then we get to place this one appropriately. Okay. Descend, same thing, just the opposite direction. Sorry. Here, here. And slow. Okay, so there's a few steps with that. Now, I'll show you the textbook way, and I'll show you the real way. This one is, so ascending I've got no problem with. So ascending, if we can hook the cane here so it doesn't fall, that's great. If it's a quad cane, it doesn't fall down anyway. But what we're going to want to do is we're going to have the cane here. We want to use our hands to ascend with the armrests. We don't want to have the cane in our hands here because, again, this is very unstable and I don't want to be tempted to push through it. So I'm going to ascend like we already know how. And then once I'm standing, then I get to grab my cane and now I get to go. To descend, I'll show you the way I think we should do it. Hold on, hook, hold on, sit down. That's how I think we should do it. The textbook says this. I have to read this because the textbook says need to hook cane on armrest of involved side. Then reach across and then pivot into the chair and then put this to this side for when we need to ascend. That's what the textbook says. So my problem with that is the more steps, the more problems. Especially if we have cognitive issues, I think it's a big problem. Probably okay for patients who have tight spaces, like that might be the best thing for tight spaces. What I do like about it is we get to be, in contact a lot, but I think it's so silly. Like if we need that level of intricate just to sit down, I can't believe we're using a cane to walk around with. So again, I think we just come up to here, hold on, put this on, and then we sit down and nice and safe. Textbook has different opinions. We'll team up and write a different textbook when that happens. So those are the big sit to stand activities for the 3 different types of assisted devices. So for the next 20 or so minutes, I just want to practice this sequencing to get it down a little bit better. Okay. All right, let's have some fun. So I think we did a good job today. Pros and cons of each assisted device, different gait patterns, not only learning them, but also pros and cons. And we can start to try to piece together which patients would use each gait pattern. And then the sit to stand, so we can start piecing things together. So next time we're going to kind of go through, okay, here's the patient scenario, get them up out of a chair, what assisted device, fit it, teach them the appropriate gait pattern and safely guard. So that'll be one of the first things we do. We'll also start doing stair and curb training. There's a lot to that, and then we'll look at some other things too. So we got plenty more to do. I had a couple of questions. I had a question about these knee scooters. I've had a few. This is a pretty big one. I've had a few different versions of these. 100% fall risk. 100%. Yeah. That one guy fell. Let's see what that. Let's see if we can find the. What does this say? Yeah, not great. But yeah, these are 100% fall risk. Yeah, I've had plenty of patients, old, young, everyone in between, and every single one has fallen. Without any, there's very few 100% in life. This is 100%. Your patient will fall if they have this. Younger person, because they're going to go crazy with it. Older person, the big problem here is in order for it to be stable, the wheels need to be wide apart. But when the wheels are wide apart, we're going to catch things. We're going to catch door jambs. We're going to catch tables. And once we catch it, this is going to jerk on their hands. And now we're going to be toppling down. If you've ever driven a tricycle, then that's what it feels like. So, in order to decrease that wheel from catching things, you need to narrow the base of support, which is going to increase your fall rate. So I understand it's for some people, it does, but it's 100% fall risk. So anyway, 4-point gait pattern. The big ones that I've seen is when people use this kind of contraption to walk. So this woman had a car accident, spinal cord injury, and a leg amputated. I believe it's this leg is the prosthetic limb. So this here is a exoskeleton, battery operated, that allows her to walk. So that machine is allowing her to walk, and she gets to use her bilateral assisted devices for the balance piece. I think we could clean up this gait pattern a little bit, but she's basically doing a 4-point, So anyway, that was not this one woman, but one of the 2 or 3 times in my life I've seen a 4-point gait pattern was with one of these exoskeletons. So pretty cool. All right, so that's it for us for today for this class. Next time we'll do curbs and stairs. That's going to take a lot, and a couple other scenarios.